the patients themselves had been coming back and telling us, I think you hurt me.
Hi, I'm Jane.
Hi, my name is Jamie Reed. I'm a whistleblower from a pediatric gender center in St. Louis, Missouri, and I'm now the co-executive director of the LGB Courage Coalition here in the United States.
And I'm Bex.
And we are
Insightful Sisters.
Hi, everybody. We're really lucky tonight. We're international again. We've got Jamie Reed with us. I'm really excited about this. Jamie describes herself as a lesbian, lifelong Democrat and healthcare professional. And in 2023, Jamie became the first public whistleblower in the United States to report on what was happening in gender clinics. She now runs the LGB Courage Coalition. So welcome, Jamie. We're so happy to have you here with us tonight.
Thank you so much for the invitation.
I'm going to pass across to Bex. She's got some opening questions for you.
Thanks.
Hi, Jamie. So the best place to start, I think, is with your background. So you've described yourself in the past as, being left of Bernie Sanders. What drew you into this field of work when you first began working in the Transgender Centre?
So my original field of study was in cultural anthropology, and I was very much kind of a punk, anarchist, lefty college student. I really was big into politics and activism from a long, early age. Even in high school was, very active in groups like Amnesty International. I was really interested in politics early on. I started working in women's health care and then HIV care. And I worked in a Planned Parenthood. And then I started working as a case manager with individuals who were HIV positive. And what I started to see in that field was this slow kind of spillover of what was referred to as trans care into the HIV world. But this was always adults. And when we were looking at it from HIV care, we were talking about how we could get HIV positive individuals who were also trans identified to engage in care. And we knew that there were high rates of HIV in men who were identifying as women. And it was really from being in HIV care and being in the quote community that I first learned that this position opened up in the Pediatric Gender Center. And it was only about a year old when I heard about this position. And I had a number of people reach out to me and say they thought I would be perfect for it and that they encouraged me to apply. And I now kind of struggle with the idea that I wasn't questioning any of it at that time. I thought that this was a new kind of cutting edge trajectory for medicine. And I figured that it would not have been started in, the hospital where I worked if it didn't have good evidence behind it and it wasn't well thought out and well organized.
I mean, that's a very rational thing to assume, isn't it? I mean, this was being delivered in partnership with Washington University.
Yes.
So when you got into the role, what were your sort of immediate impressions, I suppose, of the sort of people that were coming forward for treatment and the way things were running?
My initial thoughts actually were not about the patient population. My initial thoughts right away were, wow, this is not well organized. This is not put together. In HIV care, we had a lot of very clear protocols. We had a lot of very clear programs. We knew who was in charge of what. We knew how to work with our patients. Everything seemed like a well-oiled machine in HIV care. And I was working with young adults, so I was working with that youth population. But the difference was immediately striking that there was very little, there was no written protocol, nothing was clear, and even the type of job I was performing. So I've always been in these roles as a medical case manager. It's basically the social worker. And in HIV care, I had very strict guidelines on how many people I could help. So my caseload, could never really go over a certain number. And I come into working in pediatric gender medicine, and there was no concept like that. I was told I'm the case manager, but also the person I was replacing didn't have a case book to give me. And that's also really strange. So nobody had been tracking. They'd been open for a year and nobody had been tracking the patients. And so I came into it at that time with a little bit of a sense of, wow, this is so unorganized, but also I'm good at organizing things. So maybe this just needed to be put together better. But that was my first impression. It wasn't until, so that was in 2018. I think there's a phrase that basically a frog in a boiling pot of water doesn't realize it's being boiled to death at first. I really think that that's how I went into it. I didn't realize the controversies, but I also didn't realize we were going to see this huge spike and this change in the patient cohort until I was a little bit into it.
Yeah, so tell us about that change, because you oversaw intake. So I imagine you are in a way much more sensitive, or you were sort of one of the first to recognise these changes, perhaps before they'd filtered through to your colleagues. How did that change the service?
So the first thing that changed was just the sheer number of patients. So when I started in 2018, we would get maybe 4 new kids presenting per month, maybe 6, maybe 8. And that kind of stayed steady for a while. And the thing that I think is really important to kind of know about where I was geographically located is that I'm in the middle of the United States. We're called flyover country. We're not New York. We're not California. We're not rural, but we're pretty much like the middle of nowhere, Midwest. And so for a lot of social trends in my country, it'll hit on the coasts first, or it'll be created on the coast first, and then it'll work its way in. And then, by the time it gets to us, it's kind of been through a couple passes of like how social things like change a little bit. The time frame from when we hit the peak of these kids identifying as trans was later than when Tavistock saw it or some of these other clinics started to see it. So initially in 2018, I'm not seeing huge case numbers. I'm seeing, a couple, maybe a dozen at the most per month. By the time I left, which was in 2022, we were seeing at least 40 to 60 new patients per month presenting. So the percentage of just the sheer number of kids identifying as trans literally exploded in the time that I was working there. And then the other elements was that the patients themselves changed. So these went from your stereotypical gender nonconforming, maybe younger boys who are very feminine. The age was, normally prepubertal or right around puberty. And the explosion was in teens, primarily teen girls who had already been through most of the pubertal changes. So it was going against what even the data, the original kind of concepts around trans had shown. This was something totally different. These were 15, 16, 17-year-old teen girls with a lot of distress, with basically a sudden pronouncement that they're trans identified. And part of my role was to do the intakes, but also part of what I just have always loved about pure science is I love data. I love a good Excel spreadsheet. I want to know what everything is. I want to know how many and why and how it's changed and all of these different aspects to it. And so I had been keeping these data sets. And so part of my challenges with working in the center was there was just no basic scientific curiosity. Hey, why is this changed? Who are these kids? Why is this different from what we expected? Why are there so many? These are just questions I thought basic science would want to know the answer to. And I was really surprised to find out that those around me not only didn't want to know the answers, they didn't want even these basic questions to be asked.
Trends in healthcare and social contagions and trends in young people are very recognised across all sectors, especially in paediatric care. Did it take you aback, the lack of curiosity and the shutdown in the workplace when you tried to query?
At a certain point, I was actually starting to get angry because there was this ability for the doctors around me to recognize things like TikTok ticks. So they were saying, look, these teenage girls are coming in presenting with a form of, kind of a Tourette syndrome, but it all looks the same. And like they could recognize all these other social contagion drivers that were happening that were also crossing over into our patient cohort. And then as soon as trans came up, it was like dead stop. Nope, nope. We can't question that. Trans was being treated like a mythical unicorn, and that infuriating on some level because I had come from infectious disease. I had come from HIV. And there are these just like phrases in medicine, like if you hear hoofbeats, think horses, not zebras. Like there's all these things where you are supposed to be able to recognize trends and question. And in the moment, I just could not understand why they wouldn't be open to the conversation around it with trans. In retrospect, I realize if they allowed us to go there, if we followed the evidence and the thinking, we would have to come to the conclusion that, first of all, this is a different group of kids than the original studies, and therefore we should treat them differently. But also, it was so fundamentally in opposition to everything that trans is supposed to be this innate thing that you can't question. That it is, when someone makes that announcement to the world, it is it, and that's it. There's no questioning of it. And if you started to look at this from the data and the cohort that was coming in, it makes you question the entire concept. And I think that was a bridge too far for those that I was working with.
How did you feel sort of at that time as you're sort of beginning to have these concerns and recognize these patterns? You've mentioned before you had a colleague that you could raise these questions with, but in the wider US at that point, was there a discussion of this on the left? Where here in the UK, we had a discussion across the political spectrum.
No, there was no discussion. In fact, I was looking to the UK. Some of the materials, the articles, the things I was finding, I remember finding a news story out of the UK when a small group of providers who worked at the Tavistock quit. I remember reading that. And my first thought was, I want to talk to these people because I just felt like we were experiencing like very similar things. But I remember the interim cast report. I remember reading that and finding it profoundly like relevant to the care model that I was still a part of in the United States. It was not on social media at the time. So the one positive was I didn't know how bad it was for those who had been speaking up. I just saw these snippets in like mainstream media, and what I saw come out of Tavistock, I just felt like you just had very courageous whistleblowers who were moving the science in the right direction. I didn't know how bad the backlash had been or was for so many people across basically all of social media. I didn't realize if you said anything like trans women are men, like you would be canceled. I didn't know any of that. The things I was seeing were the big mainstream articles that were breaking through.
Within your workplace itself, we've mentioned before the hostility, and you've spoken in the past about, getting your first negative performance review and, being sort of targeted. Do you feel that there was a cover-up? Do you feel that this was an intentional silencing or?
By certain individuals that I worked with, yes. There was absolutely moments in time where they were instructing me on things that I, to this day, question the legality of. So I was told at one point to stop writing certain types of notes in patients' charts. I was told, basically they tried to find a way to figure out if they could either get me on board, as they would say, and get me to stop asking questions or really to leave and to go out. And one of the things I struggled with was this realization that if I leave, I would simply be replaced by somebody who was just gung-ho, transition all the kids, not even be willing to question anything. And what we were talking about, the part that was part of this like feeling of covering up and silencing was that the patients themselves had been coming back and telling us, I think you hurt me. Patients telling us, a couple years in that they were detransitioning, that they directly told us, I feel like you rubber stamped this, that you gave me these drugs or hormones that you didn't even ask me any questions, that hurt me. And so there was this element of let's not have any inner turmoil within the center. So they wanted me to stop asking questions. But the other element here in the US at the time was I was still in a gender center when some of the very first laws started happening that would eventually ban these interventions in about half of the states. So I was still in a gender center when Arkansas, one of the states in the South, passed its first law. And I feel like I was in an environment where we saw this like pressure was coming in from the outside too. And so there was external pressure, there was internal pressure from me and my coworker. Um, and the field was just, I think on some level, the doctors I work with just didn't even know what to do. They even said at one point, like, they couldn't scale back. They couldn't, you either are full bore or you have to completely stop. And they didn't know any other pathway.
God, that's scary. It sounds like somewhere in there was some understanding that they were, doing harm, or that they might not be sort of following the child's best interests. I'm going to pass over to Jane now, who's going to look more into how the system works and patient outcomes.
Wow, I'm listening to you, Jamie, and two words are coming into my mind: how courageous you are, but also how tenacious you are. You really stick at something, don't you?
I do. Part of I think understanding my role here is that my mom is a microbiologist. I grew up with this highly skilled scientific parent who gave me this really weird love of medicine and also hospitals at the same time. I remember, the science fair. I just remember this concept around science being pure and that science itself is tenacious and courageous. And so I didn't necessarily think that I was doing something personally. I felt like I was just doing what science asks of us, which is to ask questions, which is to, understand your data, understand your patient cohort. And I always felt like people who worked in hospitals in general were so brave just to show up to work every day. So I didn't really feel like I was doing something outside of what I was trained and raised to do.
Yeah, I mean, you seem to me to be somebody that can cope with difficult conversations. Yes. I mean, you worked in HIV, didn't you?
I did. And a lot of that's training. I mean, I've had a lot of really good training in not only like my clinical education, but just in like at the workplace. Yeah, you learn how to not only interact with patients and do that work, but some of the training that I found most important is trying to learn how to differentiate your work and your life and still have some balance. And still, I used to have this strange little trick that I would do when I would be leaving the hospital and leaving really tough patient care problems behind. When I was driving home, I would let myself think about that hard stuff. And then I would try to find a place on my route home where I would literally tell myself, okay, I'm going to leave this patient here on the route. I'm going to leave this. I'm going to take this off my shoulders so I can go home and be present with my own kids and leave it for a moment. And then I would tell myself I'm going to pick it back up on the drive back in. And so I always felt capable and able to work in a demanding field. And what was so frustrating was that gender care was not that kind of demand. It was this moral, ethical, it's not just me leaving the patient on my drive home and knowing that they're in good hands with the next shift in the hospital, but it's driving home knowing I'm complicit in a moral, ethical, medical scandal. And that became part of that driving force where I couldn't leave it because I did try to not become a whistleblower. I tried to move into a different field and leave it behind, and I just couldn't.
We're very, very glad that you were not able to leave it behind, although it must have taken a terrible toll on you. Tell us about how the team is organised, because you've got a team there. Is there a hierarchy in the way that there is in a UK hospital?
Yes. So there was an adolescent medicine doctor and an endocrinologist, pediatric endocrinologist, who are supposed to be the multidisciplinary team co-directors.
Okay.
And then there was myself, the medical case manager. There was a clinical nurse coordinator. And then we had a little bit more peripheral, but we had a psychiatrist and a psychologist, and we had a part-time kind of nurse practitioner and another person prescribing hormones. When they talk about this model of care, we were exemplary. This was supposed to be the best kind of way that this care could be delivered. We would have multidisciplinary team case conferencing. We had all of these different roles that were supposed to be looking at the patient and the complexity around this and offering up our professional opinion. Problem with this care model is that the quote, standards are really basically driven to medicalize the kid. It was to the point where basically the endocrinologist came at it from this perspective, which was, and he even would say, I don't really care if they have, quote, gender dysphoria. If they say they're trans, they're trans. And if they want to be medicalized, we will medicalize them. And that's really not that different from the way that the affirmation model kind of plays out, across multiple centers. And the problem is not the multidisciplinary team. The problem is not the way that we carried it out. The problem is the model itself, because there's no actual diagnosis. There's no way to diagnose anyone as trans. You either claim that you are or you claim that you're not. And there really is no way in medicine to engage with this concept, because in medicine, you're supposed to have a differential. You're supposed to consider other perspectives or other possible diagnoses. And, I kind of feel like on some level, this concept of trans came in and it wanted to sneak in the medicine, and it wanted to pretend like it was a medical issue when really there's no diagnosis. It's just people who make this claim and they make a demand for these interventions. And when you apply that to kids, it will never work. You can't listen to a demand of a child.
And you went into this thinking, with your HIV background, thinking there will be a diagnosis.
Yes.
Somebody's going to reveal it to me.
Yeah, well, I at least thought there would be a diagnostic process and a differential and an assessment. That's what people that still claim that they support pediatric gender medicine, will say, oh, it's a long assessment and, there's this process to it. At the end of the day, basically every kid who wanted this, we said yes to. And that was the other part of the problem. No one was ever told no.
Tell us a little bit about the population of young people that you were seeing.
Primarily girls. 70 to 80% were girls. They were adolescents. They were 15, 16, 17. They had a lot of mental health struggles. They didn't want to be a girl. And they would come in oftentimes in ill-fitting clothes, big sweatshirts, hunched over, just claiming a lot of depression and anxiety. They were not healthy. These are not healthy kids. They were not kids who had a strong sense of self. They often had a lot of problems in their family environment or trauma, but also they were an interesting cohort because there were certain things about the group. They were primarily upper middle class or middle class. They had access to the internet. They had their cell phones with them. Sometimes, you would talk to the parents and you'd find out that they had social media access 24/7. They had very little rules around social media. They were on social media apps all the time. And a lot of these girls were smart and awkward and quirky and weird. And they were coming in claiming that they were trans and that they wanted testosterone immediately.
Yeah. And they were given testosterone fairly immediately, weren't they?
Yes, a lot of them.
How do they get referred in the States? How do you get referred to a clinic like this?
You could self-refer. You could direct yourself. You could also get referred from your pediatrician or your general doctor's office. But we were open to kids coming who, I mean, if a kid made an announcement that they were trans identified and their parent Googled us and found us, they could be seen pretty quickly.
And were they all in state, or did you get kids coming from outside?
When we started to see some of the states around us passing laws against these interventions, we did start seeing more patients coming from like outside. But for the most part, our patients were from probably a 60 to 90-minute drive from around us. I'm in the major kind of city in the area. And that was the other thing I found of interest, is kind of where these kids were coming from. They were coming from, again, like for the most part, areas that had, they had health insurance in our country. They had access to medical care. They had parents who were almost always liberal kind of parents who would either jump on board, or, some parents I worried were the drivers of this too.
That must have been scary.
It was yet another element where I wanted at least that basic scientific curiosity. This is interesting. Like, these parents are seeming more interested in this identity than sometimes the kids, or the parents would talk about how they had, one mom had said she had kind of a tomboy kid, and she had bought all of the kid books about trans online and sprinkled them through the house. And it was like, what are you doing?
Yeah. Gosh, it's almost like the parents, the cheerleaders for them, isn't it?
Yes. And we see that in a small group of these kids too. The parents got something out of it.
You talked about the roles and responsibilities, and you've talked about diagnosis and the affirmation model. What if a young person clearly wasn't just trans identified, supposing they had these other issues? How did you deal with those other issues alongside the gender medicine?
We really didn't. We would affirm, we would give medication, we would give cross-sex hormones, and we would basically try to refer out or see if somebody else could manage those other issues. A lot of what the thought process was that the depression, anxiety, all of those other mental health issues, the thought was that those things would go away if we would affirm the identity, because there was this concept that it was that being trans is very challenging of itself, and that the social pressure, or the social, that basically if we would affirm the trans identity and fix that part, then the other things would go away.
So no safeguarding. No. Was that a discussion ever?
No. And the word that's used inside of the gender center is gatekeeping. So it was not considered, are we safeguarding, but it was, are we gatekeeping these things from trans identified people who, that they just deserve, that this is just their medicine and that they should just have access to it.
That's so interesting, because gatekeeping suggests that you have the treasure behind the gate, whereas safeguarding suggests you're trying to keep people safe. It's such an interesting turnaround, that, isn't it?
Yeah. Yeah.
So you made yourself quite unpopular. You started raising these issues.
Yes.
What happened to you? How did that impact you in your workspace? That must have been really hard.
I have basically been navigating ways to be self-employed ever since. It's not uncommon. A few of the books I've read around whistleblowers is that many of them will never work in their field again, and portion will never work again. But it actually has not. When I initially became a public whistleblower and my story broke in the publication here in the US called The Free Press, I think the initial wave was very challenging. But after that came the secondary wave, which is that there's this whole network of amazing people that had been working on this for years before I ever came along. And they really welcomed me into this huge coalition that has been around, that have been working around principles of medical ethics, but also it wasn't until after I became a public whistleblower that I fully got to begin to understand the angle around how this has harmed women and girls in particular. and how much and how many people had been raising the alarms from that angle for years, before I ever became public.
So you left your role, didn't you? And you started a new job, and it was then that you felt able to sort of collate your thoughts, I suppose. Is that fair?
Yeah, it took about 3 to 4 months. And then I got an attorney and then filed a formal affidavit with the state of Missouri and became a formal. Yeah, I moved into working as a clinical researcher in pediatric hematology and oncology and did that for, yeah.
Another area where you've got to deal with big emotions. You're a big
Yes.
emotions girl.
Yes. Yes. Yes.
So you tell us about the whistleblowing process. How was that? And you're smiling.
I think it worked out the best it could have. But I now talk to, new whistleblowers, and it's one of the most, you never know what's going to happen until you just do. You're just jumping into the deep end and you don't know what's going to come your way. Process-wise, I reached out to an organization called SEGM, the Society for Evidence-Based Gender Medicine. I wrote an email to them, totally cold email. I had no idea if anybody even read their emails. I found their website and I just said, listen, I worked in a pediatric gender center for a number of years and I think I need help. I think I need to make what I know public. And they put me through a number of hoops to make sure that I wasn't a mole or that I really was who I claimed to be or that I really knew what I was talking about. And then I was linked with attorneys. And then attorneys really are like the gold standard. You have to work with legal representation. And they were with me every step of the way. And then I met with the Missouri Attorney General here in my state, and I filed a formal affidavit and I provided with them documentation and all of the evidence that I had. And then it was only after completing those steps that the story broke in like the the journalists kind of knew then.
And did a lot of mainstream media pick it up?
Yes, but from very weird angles. Even my hometown paper, they didn't talk as much about my allegations. They talked about the fact that my attorney was a Republican. They were very defensive of, and they still are very defensive of the model. And I think there's still a huge divide in this country over how this even gets talked about. It's almost like we're speaking two completely different languages, and it's very hard for those conversations to even intersect sometimes.
I think that's the same here as well, actually. Sometimes I feel that we use almost the same language and mean different things. Yeah. It's quite strange. Have you had ex-colleagues and other healthcare professionals reach out across to you and talk to you about this?
Absolutely. I have had others within the hospital system where I worked at, but also from around the world. I've heard from other physicians, other individuals who've worked in gender medicine. I've met and know a number of your Tavistock whistleblowers personally. I have had really amazing connections with a lot of really intelligent, thoughtful people who came to similar conclusions, sometimes from different pathways. But the thing that I'm so impressed by all of these other heretics is just this willingness to let the science lead you, let the evidence lead you, and go where it goes.
One of the big differences between the system we have in the UK and what happens in America is how healthcare is funded. And I think that has a bit of an impact because, well, our healthcare statistics are centralised, so that's useful. But also, healthcare is free. So whether you're on a waiting list or not is another issue. But healthcare is free. That's different in America, isn't it? And what impact do you think the sort of lack of centralised data, but also the insurance issues, what impact do you think that might have on the future, I suppose, of transgender medicine?
I have often felt that the UK and Finland and Norway and like the other countries that have similar models to the UK have been at an advantage in some ways of getting back out of this. So you had, exemplary national review, the CAST report that we would never have here. And I have initially thought that I was saddened that we didn't have similar ways to move forward in the US like your countries do. However, I know one of the things that they're struggling with in the UK is getting the ability to match up some of that data. So the adult cohort that came out of Tavistock, or the adult centers that have been medicalizing individuals, especially in this like cohort of like the young adults who were hugely impacted. I know you're still struggling with getting that data set. So it's a challenge because at least your data set exists, and then it becomes the political will to allow that to be analyzed and that to be looked at. We don't even have that kind of data set. So even if we had the political will or the driver to analyze that, no one had been collecting data like that. The data we collected is more like insurance billing codes and maybe the expenses and the use, but it's not that same kind of rich ability to really look back and assess that you have. With that said, I think that makes it really important for countries like mine to be willing to hear from researchers. Like in Finland, Rita Katiala just recently put out a really important paper because she does have those records. So, I think just in terms of pure science, I think you are going to continue to drive some of the purely scientific understanding of what has happened and how to move forward. And what I hope maybe America could bring is some of the political will or that driver or push to scale some of this back. So if anything, I would hope that there are ways that we could partner, that your data, your information can help us, and then we can continue to push on the political will.
I think I've wondered and hoped that the insurance that you use in the States will be a driver, because if this is going to cost money, if people think at some point there'll be a class action.
I don't know if we'll see a class action, but what I would hope is that we would see, like, we have all of these angles here. We have bans in some states, but if we can get this out of insurance coverage, that would also push it into fewer families' lives. So if it is something that you would have to pay for completely out of pocket, that is not covered within an insurance idea, anything for me to bring down the numbers of those being harmed by these interventions is a tactic I would like to see somebody work at and try.
Well, everything. We'll use every weapon, won't we, to try and turn this around. Did anything in your own hospital, has anything changed since you whistleblew?
Yeah, so maybe within about 6 months, we saw a law pass in the state to make these interventions no longer legal. So puberty blockers, cross-sex hormones, and surgeries in minors for any new patient presenting was no longer legal.
Well done.
It was a huge win. And then we saw a huge number of states kind of domino fall after that. But we've almost reached a stalemate here now, where about half of the states have these bans on the books and half of the states are still pushing and allowing these interventions to happen. So we're still in the middle of it. And I think that the UK is in a similar position as well. There was a research study that, was hotly debated. I don't know that we have yet come up with a good pathway out of this that can be universally applied.
We're all waiting for the drama. Somebody needs to do a drama about this. It's true though, isn't it? Because sometimes the story on the screen is really effective. I'm thinking of those, what was the pain-killing drug that it...
the Oxycontins and all of those.
One drama after another, and it's absolutely gripping. And you can see this impacting on real families' lives.
Yes.
But what you did in your whistleblowing ventures, you really turned things around for the whole of America, I think. Would you agree with that? Is that fair?
I have heard very similar things, and I am still to this day incredibly proud that I was able to, in essence, peel back sort of the curtain and show what was truly going on inside of this center. And I think that my center was basically incredibly similar to most of the other centers here in the US. And it showed a completely rogue medical model that has been harming kids. And I still work every day to get this to stop. One of your whistleblowers in the UK said to me, we have our duty. This is our duty. We participated, and our duty is to work until it's ended on the other end.
Yeah. Well, thank you for that. I'm going to pass you across to Bex. I think she's got a last question for you, and then our final question. So I'll pass across to her.
So, looking forward, how does this fight continue for you now? What do you see in the future?
So the organization that I co-founded and now run, we work on legislation, so legislative efforts to try to get states to stop the use of puberty blockers, cross-sex hormones, and surgeries. But we also, I think, work really hard on the concepts around like the social change, the conversation. The driver of this was not always just medicine. Part of this was also a huge cultural shift that we have to address. We have a weekly gender news podcast. We put out articles. We are following this, without stop. This is, basically, people have said this is one of the greatest medical scandals of our time, and it's still unraveling every day in front of our eyes. I'm just in it until the end, and I don't know that we will ever have an end because there's so much to work through. We still have to work through women's spaces, sports, prisons, the medical side. There's so many elements to still work on that I think I have a full plate until I'm really ready to retire.
Yeah, it's not going to be like a dam break, is it? It's going to be a long, slow path to change, I think.
It is huge changes. Yeah.
Perfect. So that brings us to our final question, which is, do you have a woman or women of the moment?
I do. So 2, one of them is from the UK and one of them is in Australia. So right now, Gillian Spencer, whistleblower out of Australia, was at her conference, the conference for the mental health professionals in Australia, and she is continuing to push the boundaries there. She held up a sign silently during the keynote speech because they had removed a doctor who was asking about these medical interventions. So Gillian Spencer in Australia, and then Anna Hutchinson from the UK was just here in America and just spoke at yet another medical conference, where the stage was rushed and she really was put at great personal risk. Right now, I am just so in awe of these women who not only originally became whistleblowers, but are continuing to do the work every single day and realize that, free speech right now on this issue requires putting ourselves on the line. And those 2 are both still doing that.
Great picks. Yeah, absolutely great picks. Thank you so much, Jamie. This has been fascinating.
Thank you for having me.
Thank you to our listeners. We really hope that you've enjoyed this episode. And if you have, please do like, share, comment, subscribe, all that good stuff to help keep our channel growing and spread the word. Thank you.